At 9:35 in the morning, and it's a Tuesday, and you know what that means. That means we spend some time with our friends over at GRMC with your healthcare partners, brought to you by GRMC, Guam Regional Medical Center, where patients are partners. And may I introduce to you, and I hope we put the camera on the lovely face on the other side of me, Dr. Akua Agyeman is in the studio with me. Good morning.
Good morning.
How are you?
Very good, thank you.
Now, she is the Deputy Chief Medical Officer.
Mm-hmm.
Congratulations.
Thank you very
Boy,
much.
they just walked you right in and put you in the top chair. and of course, she's the Adult and Pediatric Hospitalist.
Yes.
What does that mean? Hospitalist.
Hospitalists are essentially doctors who work in the hospital on the wards, and I am doubly board certified on internal medicine and pediatrics. So I work on both the pediatric side and the medicine side.
Oh, so you've got them all. You got all ages.
Pretty much.
Wow, you cover all
from birth to death.
Yeah, no kidding. That's the lifespan. You're in the zone there. I mean,
yes.
Is there anything any more that could be any more complete than the health from birth to death?
That's why I chose it.
Wow. What? No. Okay. First of all, the accent.
I'm going to disappoint you. I'm American.
Well, no. I'm going to disappoint you.
More exacting than it sounds.
I'm Chamorro, born in Texas, and I'm American too. But the accent. You come from Ghana.
My parents are Ghanaian.
Your parents, and so were you born? You were born there
in the U.S.
There? You were born in the U.S. Okay.
Lived in Ghana for a number of years and then went back to the U.S. and have been there. And then now living in Australia.
Okay, so you've been everywhere.
Yes.
So your parents are from Ghana. They decided to...
They immigrated to the U.S.
And then they went back.
And then went back.
Okay, why did they go back? What was the purpose of that?
60s and race issues. So they decided to go back home.
And then when things settled down. Well, things.
I said, I'm not staying. You can stay. I'm not, and I ran away and went back to the U.S.
Did you? Okay. And then you've been educated. I was looking at your curriculum vitae, and you have been very well educated on the East Coast.
Yeah.
Yeah, mostly, and so that's where you settled in the East Coast. That was your
I
place.
was born in Manhattan, so I went back. To my roots and kind of been between New York and New Jersey.
Well, ma'am, you are far away from New York.
Yes, very.
Is there a bit of a culture shock coming to Guam?
No, because it kind of reminds me of Ghana, actually.
Oh, yeah.
Yes.
Really?
The culture is very, very similar.
Yeah.
So
tell me the culture of a place like Ghana and a place like an island culture. In our culture, and I'm pretty sure that you know this, that we celebrate and we take extra good care as just as a matter of birth of our young and our elderly.
Same thing. Very much an African culture is being very respecting the elderly, loving the children, having more than a nuclear family, having extended family, that sort of thing, and lots of gatherings around births and deaths and celebrations. So it feels like home. It feels like home.
Yeah. It feels like home here.
Yeah.
So as a hospitalist, as sort of an in-house doctor, you are the one.
Pretty much.
Okay. So along with the specialists that you work with, depending on the person's condition, then are you seeing mostly patients that have need specialty care? Or not necessarily?
Oh, gosh. I think that's probably one of the biggest things I love about being in Guam. Because I live in Australia and I've been working in rural and remote, and I actually have a fellowship in rural and remote medicine in Australia. And one of the things that is very difficult is having access to specialist care. So when I came to Guam made me so excited that it was a similar sort of need where you would have primary care resources, but not a lot of specialist care. And even in Australia, I'd have to try and fly people, thousands of miles away. And to have a hospital here that can actually provide all that care on island and have nobody have to leave. And also to see the quality of doctors that were here and the sorts of things that we could do. That was very thrilling for me.
Was it a matter of distance or socioeconomic differences or both?
It's distance. Australia is a very big country, almost as big as the U.S., but very sparsely populated along the country. So all the regional resources have the subspecialist care, and the primary care is spread out all up and down the country. So most of the regional centers you have to fly people into. So we do a lot of life flight sort of things for STEMIs, for sepsis, putting people in ICU, etc. And so to come here and to have a hospital here that had built all that stuff where people no longer had to go to, mainland U.S. To me, that was very exciting, and some of our doctors are doing some pretty incredible things here.
Yeah.
So that's I think a real plus for them.
And you're a drive away. You're literally just
exactly.
A few minutes. So it feels good to practice back in the U.S. basically.
Yes. It's excellent to be practicing U.S. care and to have access to that level of care on island.
Well, you could have. I'm looking at your experience and your education. You clearly could be doing this in Manhattan.
Have been offered many times.
Yeah, but you, and obviously you have a sense of adventure and maybe a sense of humor because you go off to far-flung, remote places in the continent.
That's what I like to do. I like to make a difference.
Yeah.
So coming to places like this where otherwise they wouldn't get access to that level of care, I feel like I'm needed, and I feel that it satisfies that passion that made me go into medicine.
What are you seeing? What are some of the conditions that you're seeing among our? Let's just start with the age group of children.
Mm-hmm. Well, pediatrics, we have a lot of the typical things: lots of asthma, lots of bronchiolitis, arthritis. Surprisingly, we are getting a lot of early newborn, so NICU level of care, which has been quite surprising to me. I think it's probably because of the diabetes that we have on island, and a surprising amount of asthma also, which I can't quite explain.
Is it really surprising in a tropical climate?
Well, asthma in general is on the rise, just across the board in all countries, and we're not quite sure why. There are some thoughts that it might be an inflammatory reaction to toxins that are in the air, etc. So we're seeing that everywhere across the board, but in more, how shall I say, native populations, it's unusual because they usually tend to live very close to the earth. They're not living in polluted spaces most of the time. So it's been surprising to me the level of asthma something is going on.
You think that
we haven't put our finger on yet?
Like a cusp of some kind of environmental evolution?
Yes.
Because I noticed that there are a lot more numbers of kids than you would think because you live in the tropics and the breeze that goes through.
You've got the sea breeze coming through.
Yeah,
here,
you don't have stagnant air.
Exactly.
Okay.
So just asthma in general has been surprising and disappointingly over the course of years we haven't really made a good dent in the numbers of deaths, etc. So that's been.
Do you think that might be coming from coral? Because the corals being exposed through construction and the dust and whatnot being up in the air?
It could be. And also I think we're having a lot more earth-warming events, and you've got much more turnover of water, so we might be exposing new toxins that people are not exposed to. Yeah. But this is happening across the board, even in places that don't have water. Yeah. So why, it might be, there's lots of theories out there about it, but that's one of the unusual things that when I came here, I saw that like everywhere else, we have that as well. Can
I touch on this topic of asthma and the expertise that you have on this condition? What I understand from a lot of parents who don't recognize that it is asthma. First of all, is that correct? A lot of people.
You're very right, and in fact, that's some of the reason why it's missed for a long time, and why sometimes you have adverse events with it. And like I said, typically, as long as we've had asthma, despite all the many treatments we have, the management of asthma continues to be a hit or miss for the most part. So there are lots of policies that have come out, guidelines that we follow to try and make sure that we are doing the same thing every time. Yeah. And that's something that we're doing to try and delve into that.
I think that's a really important point, because what tends to happen once a parent finds out that the child has been diagnosed, right? They begin a series of treatment, and once the child looks like they're relieved,
they stop
the treatment.
Exactly.
And then some of the medicines may be out of reach financially. So the assessment is that they stop taking it, and the kid
because they think the kid's better.
Yeah, and so does that mean then the kid then comes back with it worse?
Yes. In fact, some of the molecular studies and the pathologic studies that have been done on people with asthma in their lungs is that even when you have what we call silent asthma, the disease process is ongoing, so that the lungs actually get much more fibrotic. Yeah. So that instead of having thin lungs that are nice and able to exchange air very easily, your lung tissue gets thicker and thicker, so that air exchange doesn't occur as as efficiently. So that fibrosis happens when you're not taking the medication, so that your asthma becomes much more difficult to control, even though you have no symptoms while it's going on.
Do you think that pediatricians that treat a number of childhood ailments recognize always that it's asthma?
No, it's like anything else. It can have a lot of different presentations, and particularly when you have like the nighttime cough or the sports-related cough, it can be very difficult to diagnose. And you have to be seeing somebody fairly regularly. And, it masquerades as different things also.
It really does. And
so it can be sometimes difficult to diagnose when it doesn't present typically.
Because sometimes I'll see, like, new parents who've taken their child, and the doctor, they say that they're having a tough time bringing or whatever. I don't know how far, and I don't ask, but how far into the research that they do, because the kid comes back with a puffer.
Yes.
And pretty much that's the only thing. And that's just a temporary relief for an attack.
Yes, exactly.
Right? So, but they're prescribing it as a course of treatment throughout the day, like 2 or 3 puffs throughout the day.
Yes.
Is that dangerous?
It can be. Depends on the kind of asthma you have. And the guidelines say that we have to quantify the type of asthma that you have. And if you have exacerbations, or you cough a lot more, or you have a lot more breathless episodes, wake up in the middle of the night with it, you are supposed to go on a preventer.
Yeah.
And so most people, there are quite a number of people who are on the rescue medication who should be on a preventer. And so long as they use the puffer, it opens up their lungs temporarily. They feel they're better, when really they should be on the preventer.
There's a series of medicines that you can take on a daily basis.
I think my message would be for every parent who suspects asthma, who thinks their child has asthma, or who's diagnosed with asthma, the one thing they need to remember to ask their provider for is an action plan, an asthma action plan.
Good point.
That ensures that they are following the protocols that we're supposed to do.
Good point.
So that even if the doctor forgets to keep reminding them about it, they at least have the action plan, which details what it is they are supposed to do for different things.
Yeah.
Makes it a little more routine how to manage it. So.
Actually, take an active interest, because it can definitely get out of control if you don't know what you're doing.
It can.
Is it a plus or a benefit to have a hospitalist at a hospital, or is that a requirement?
There are some positive things to it, and there are some negative things to it. As a hospitalist, I've done both primary care, private practice. I've done outpatient,
done it all.
and I've done done inpatient. Personally, I prefer being a hospitalist just because I see a higher acuity of patients.
Yeah.
And I think when you're in hospital and that's your specialty, you tend to become very, very good at it. But what you lose is the outpatient connection to the patient. When I was doing primary care, where I did my outpatient clinic and then I followed the patient into the hospital, I had the continuity of care. I knew what the patient looks like outpatient, and then followed them into the hospital, knew what had happened to them. So I think if you can get that continuity, and you have a doctor who's just as good inpatient as outpatient, that would be my model of care that I'd prefer to.
You've got somebody at the back end and the top end, and you're in the middle.
And exactly. But at the moment, because a lot of doctors, that used to be a very lifestyle-intensive thing. And I remember when I was doing it, I barely had time to raise my family, because I was in with patients all the time. I wouldn't get home till about 2, 3 a.m. in the morning. And I had children that I was raising. So it wasn't my preferred thing to do at that point, because it just took a lot of time. And I think that's why a lot of doctors got out of it. At least if you're a hospitalist, this is your specialty. There are very limited hours that you do it. And then when you're done, you're done. And so you get a little bit of the lifestyle part of it. And the outpatient guys don't have to go finish a full outpatient day and then go inpatient as well. So so long as the two of them speak to each other, I think you have a better outcome for the patient, where you have a specialist hospitalist, and then you have somebody focusing and specializing on outpatient.
Well, I think it just sounds like, like the free side order, to the complete meal, to have a hospitalist.
Yes.
Because as a patient in the hospital, without the presence of my doctor all the time, it's great to know that there's somebody there that can attend to me in the wee hours of the morning.
And by the time you show up, and we've seen you once, every time you come, we know what's going on with you. So especially for those people that we call frequent flyers, who are quite sick often, you get to know them very well, and it's almost like you see them on outpatient, because they're just in with you all the time.
Here's the only thing that bothers me about these interviews is that you guys make me want to go to the hospital.
Oh no!
I mean, it's just
to visit for a tour.
It's like I hope I get him.
Yeah, I hope I get her. I always say to patients, may I see you in town, not in the hospital.
Please, Well, you've got a great bedside manner.
Thank you.
Does it take a certain personality? Is that something that you're born with?
I love what I do. I love what I do.
Did you always want to be a doctor?
Always.
Really?
Always. I think it was age 6. that I told my parents I wanted to be a doctor.
See?
And that's what I did.
And so all of that, the whole time, I mean, it's expensive. It's expensive.
Painful. It's a suck on life. Takes away your whole life for years.
But yet here we
but
are.
Very rewarding.
How long have
very
you been?
Rewarding.
How long have you been a doctor now?
Hi. Let's see. I graduated med school in '98.
Okay.
Yes. And
so you're just a baby in the biz.
Oh, thank you. Thank you.
Well, I hope I do see you more around in town.
Yes,
I hope that I don't actually have to see you in. But
not in hospital, but yes.
Yeah,
but I mean, definitely, I think I'm really proud to be part of the GRMC family.
Yeah.
And we're here for the people of Guam.
And you're here for a while. 16 months in. And your children. You have children here as well.
They're in the mainland.
In the
US,
mainland.
Yes.
Okay, so you're solo, are you?
Solo.
Here? Oh,
yes.
you need things to do, girl. Oh, I got time. Okay. It is such a pleasure to meet you.
A pleasure
Thank you
to be
so
here.
much.
Pleasure
Come
to be
around
here.
again anytime.
No worries.
All right.
Happy to.
It's 9 minutes before 10 o'clock. That, ladies and gentlemen, is HealthCare Partners, brought to you by GRMC, where patients are partners.